Thank you for inviting me to talk about this, and I actually have extended the talk not just to talk about cytokine release syndrome and neurotoxicity, because there is more to be said about complications that we might face when we give CAR T-cell therapy to our patients. These are my disclosures relevant to the talk. So the structure is I would like first to go around the grading of cytokine release syndrome and neurotoxicity for the pivotal trials that are left to registration. I really would like to also highlight that the incidence of CRS and NTX and neurotoxicity is quite different between different disease settings and the respective outcomes. Then, of course, there has been a lot of work being done on actually getting a consensus how to grade cytokine release syndrome and neurotoxicity. Guidelines are being developed. I will present what we do at our center in Würzburg with our experience with CAR T-cell therapies. And for me, very important is also to touch on ID issues, because that seems to be an underestimated problem in these patients that we are seeing. So cytokine release syndrome, what are we talking here about? This is actually based not on the CTCAE for 0 criteria. It has actually been used more the Lee criteria that was published in Blood a couple of years ago. And to recognize cytokine release syndrome, you really have to recognize that it is not just fever as a constitutional syndrome and fatigue, but it can also present with skin rashes, GI problems, respiratory problems, renal problems, etc. So it's actually more a syndrome than not just one single specific situation. So based on this kind of different patterns that can occur, there's a grading system that has been used. Grade 1 means it's not life-threatening, was in the clinical trials always controlled by fairly simple measurements, usually using paracetamol, for example. Grade 2 means usually hypotension, hypoxia, but mainly requiring just patients being treated on the general ward. Grade 3, patients definitely move into the ICU space, need vasopressors at that point, need oxygen requirement. And grade 4 obviously is life-threatening, needing intervention of maybe 2 vasopressors, intubation, and etc. And of course grade 5, that's what we really don't want to see here. So this is kind of the summary that was reported by Lee in the paper, what to do with these patients. And it's actually, I think, sort of a very simple strategy that was applied throughout the clinical trials. So what about neurotoxicity? Well, neurotoxicity was graded usually in the clinical trials that led to registration of an NHL and an ALL based on the CTAE criteria. And I just sort of took this photograph out of the current PDF file, and you can imagine when you just look under nervous systems disorders, there's 104 to 114, so there are 10 pages that you have to dive into. And the psychiatric disorders, another 4 pages to so that is basically what makes up the grading of neurotoxicity, which is complicated. It's very complicated. So now just dump into the data. So, and then we'll talk about the 2 products that are now licensed in Europe to be given to our patients. One is the ZUMA trial, which led to the registration of one of the CAR products. I would like to focus on grade 3 and grade 4 events. Grade 3 events and 4 events with cytokine release syndrome were reported at 12% of the patients, so meaning going on to ICU. And grade 3-4 events in getting neurotoxicity were reported in this trial at about 26% of the patients. So you saw this slide here. You have to be very aware when this happens. Cytokine release syndrome occurs usually early onwards, within the first 1 to 2 days. It's seen mainly in all patients. Almost every patient will get fever in that situation. But the question is, what happens to these patients? Do they then travel on to get grade 2, grade 3, grade 4? And this really needs quite intensive monitoring the patient. As my previous speaker already said, you really do need patients, staff to be trained to realize that. And very frequently, if a patient gets cytokine release syndrome, neurotoxicity will start to kick in. But it's a little bit delayed. It is a little bit delayed on the onset in the situation. And what we have also found is that cytokine release syndrome quite often heralds neurotoxicity. It's very rare that neuro just happens by itself in the situation. So based on this chart, you can see that the majority of the symptoms occur within the first 14 days. Hence, the EMA has sort of set to us as a recommendation for all the national countries that are using now cards that we have to actually keep the patient inpatient to monitor for the patient for this toxicity. But to be aware of, neurotoxicity can also occur later onwards. There's maybe 1 out of 10 patients that down the road, beyond day 14, day 17, day 20, day 28, and even some patients being reported all the way out, even 2 months out, may get neurotoxicity in this situation. And we don't know yet how to identify these patients. Who are these late onset neurotoxicities? So what about the other product that has been licensed? This is sort of data of the JULIET trial that was published just recently in the New England Journal. The incidence of cytokine release syndrome being grade 3 is 15%, so very similar to the other product. And neuro events, slightly lower rate of about 8%. But keeping in mind, we're talking about 2 different patient populations were treated in both trials. So in my mind, they can't be compared, the data, in the incidence of either CRS or neurotoxicity. I think what is also important, and this is seen here, what you can really see is an incidence, is the prolonged cytopenia that was reported here. And this occurs in 15% of the patients being on day 28 having ANCs below than 500, leading to infectious complications and febrile neutropenia in these patients. So what about the cytokine release syndrome? What was the onset there? Onset, again, early onwards, day 3. Patients came on with this here, median duration 7 days, and hypertension requirement, patients needing even IV vasopressors was in the range of about 28%, and using intubation was required in 8%. So I think the toxicity between the 2 products, to be quite fair, is in my mind more or less the same. So what about ALL, this other indication? So all of us are aware that the trial that has led to it was in children. It's not a trial that was done in adults, because the median age of this trial was 11, and the majority of patients were in the role between 3 years old and 18. So you really can ask the question, what does age make an impact in the situation? Keeping in mind, we're talking about ALL, which is a different beast that we're talking about here. Neuro events were seen grade 3 again here at 10% in these children, and cytokine release syndrome in 16% of these peds in the situation requiring ICU intervention. So what is the profile of adults? This is sort of not an indication beyond the age of 25 and not licensed in Europe yet. Severe cytokine release syndrome was seen in this situation by J. Park in patients with our morphological disease, so more than 5% blast. 42% of the patients come down with grade 3, grade 4 cytokine release syndrome. So that's a really different rate than the pediatric population. But also Jay showed in his paper that if you have a lower disease burden, if you're in an MRD situation, the rate of cytokine release syndrome is definitely much lower. So this actually mirrors what we also know from blinatumomab, that only patients with blina get cytokine release syndrome who have disease and not the MRD situation. Different here again in the neuro situation, grade 3, grade 4 was seen in 35% of the patients with morphological disease, and the numbers are quite small, and very similar rates also in the minimal residual disease situation, mirroring exactly what we saw in blina. The neurotoxicity is not depending on disease burden in these patients. So I think which was very interesting in ALL to also look at this, and because of the incidence is so much higher than the other diseases, is looking at the correlation between cytokine release syndrome incidence and severity and the neurotoxicity. And it is quite clear that the patients have to have cytokine release syndrome, at least in the ALL space, to develop some sort of neurotoxicity in situation. It's only very rarely, also in this trial, that we saw patients coming down with neuro who didn't have any signs of CRS. So what is the biology of cytokine release syndrome, of neurotoxicity? Well, we think it is cytokine driven, and there are some things that might speak to that. What we first see that patients have to have who get severe cytokine neurotoxicity usually have a higher CRP rate, higher ferritin, and also a higher rate of cytokine release, but also a greater expansion of T cells. And what we also see, and this is something very similar like the blinatumomab experience, that the blood-brain barrier is destroyed between these patients. And this is shown here that we see that the T cells, as well as cytokines and the drug, both influx into that space in those situations. And this is sort of also looking at the cytokine profile in those patients having neurotoxicity in comparison to the patients who didn't get any neurotoxicity. And again, there's a clear difference in balance. So I think it is quite plausible to believe that cytokines are really driving the show in making neurotoxicity in these patients. So obviously, we're talking about now CD19 positive disease being targeted by CAR T-cell therapy, ALL, and non-Hodgkin's lymphoma, and the CLL data I sort of just left out because it is kind of very similar in situation. But what about the other indication that we're exploring at the moment in the heme space is multiple myeloma, targeting BCMA. And here we do learn some lessons. Cytokine release syndrome occurs, but in this clinical trial, the grading was much lower. It was just like 5% of the patients coming down with cytokine release syndrome. Is this something that we are learning how to handle this better? I don't think so. I think it has something to do with the target that we are looking at. And this is, I think, really clear when you look at the neuro events. In this trial, it was just 1% of the patients having neurotoxicity in this cohort. So I think target is very similar. And this actually mirrors the experience that we have with the bispecifics. All the trials with CD19 targeted bispecifics, you get neurotoxicity. All the trials where you don't have CD19 bispecifics, you don't get any neurotoxicity. The management here was very similar. The onset was very similar. I just don't want to go through the data, but it's really very clear that there is a very early onset, slightly delayed in the myeloma patients, but very similar. Obviously, the use of TOCI was lower than what we have seen in the other NHL patients. So in summary, these is just sort of what I believe are risk factors for cytokine release syndromes and neurotoxicity. CRS is seen mainly more in ALL than in NHL and multiple myeloma, currently data. The disease burden, I think, is very clearly shown by J. Park's data that relapse versus MRD positive patients, there is a difference in that. The expansion of CAR T cells in the host will also predict if that patient will get more cytokine release syndrome. The cell dose has been shown and age. And for neurotoxicity, I think there's a very clear picture now emerging that if you're targeting CD19 positive disease, you will get neurotoxicity. You're at risk at least for it. If you're not targeting CD19, most probably not. Or if so, it is correlated to cytokine release syndrome. So I'm not certain if that is the same. Grading of CRS makes a big difference. Grade 3, grade 4, you get more neuro. If grade 1, you get less neuro, the disease burden, and the age. But now coming to looking forwards. What are we going to do in the future? I mean, we talked a lot about this, how to capture the data in our real life. And we are faced with a situation that we have a whole bunch of grading systems that we're using. We've got the CTCA 5 criteria, we've got the CARTOX 10, we've got the LEAD criteria, we've got the experience of the Sloan-Kettering system, we've got the CARTOX, the PEN criteria. I don't know, there might be several other ones that we may be talking about. This is just like a little, looks to me like looking at the stars at the moment. So, finally, we're coming together here and trying to harmonize what we're seeing. So this is a consensus paper talking about grading CRS at 2018 that was just published very recently. It's still impressed by first of all Lee, looking at very simple criteria, looking at this here, and I just don't want to go through it, but I really like the idea that we are summarizing now very simple parameters to classify the patients in grade 1, grade 2, grade 3, and grade 4. And this is going to help us a lot if we are reporting our CAR T-cell patients to the EBMT or EHA initiatives of capturing real-life world data in these patients. Similar, there's now an algorithm being developed, and I just would like to show what we do at our institution. Where we have a grade 1 CRS, we usually give them paracetamol in the situation, escalated to ibuprofen. We really look that the patient has a lot of fluid intakes because they have fever. They have, of course, a higher consumption. We only consider TOCI if the patient has prolonged fever more than 3 days, and if so, we just give 1 shot of 8 mg per kg in this patient with 1 shot of dexamethasone, and that's it, and do in every patient with fever an ID workup. This is absolutely mandatory. Fever doesn't mean cytokine release syndrome. It is ID also behind the box there. And if the patient is neutropenic, we give them GCSF. Grade 2, we start out giving the bolus of IV fluids in that situation to maybe get the patient out of hypertension. We increase our cardiac monitoring those patients. We give TOSI at 8 mg straight away in that situation, one shot with Dex, and we continue fever management of above and use supplement oxygen if the patient requires that. Grade 3 means transfer to the ICU at our institution. We use vasopressors, we continue TOSI up to 4 times. That is the license that we have for TOSI at the moment. 4 doses altogether, given 8 hours apart with max of 4 doses about that. Dex is given every 6 hours at 10 mg. That's what we do at our institution. And obviously you can also give methylprednisone at equivalent dose. That's up to you, I guess. You continue to, of course, to take cardiac and monitoring these patients and supplement oxygen. And grade 4, that's something where we don't want to go into. Unfortunately, we have never been there either in grade 4s, where we really do have to act with giving methylprednisone at 1 kg per day for 3 days to be followed up. And then if the patient needs respiratory assistance, they have to go onto the ventilator. More complicated, I think, is to really to look at about how do we decipher neurotoxicity. And I really like what is happening now, that we call this not anymore neurotoxicity, because this is immune effector cell associated neurotoxicity syndrome, because it is a syndrome, because it takes a whole bunch of different things to really make this call neuro 1, 2, 3, or 4 or 5. And this is consensus paper, which is really great, and really recommend everyone to read it, because it really gives us not anymore the CTAC criteria, 10 pages. It all is summarized in 1 page, how to grade these patients and to box them into the different grade 1, 2, 3, and 4, which then leads down to how you treat these patients, that situation. And I think what is very important is that you have to train your nurses, because there is a ICD score that is very simple, where you actually look at the orientation of the patient, at the naming, the following commands, writing, attention, and that can be done maybe once a day, twice a day, and if neuro it comes on, if you get the ICANS syndrome, then you have to increase the system much frequently, because you really have to capture the patient traveling between grade 1, grade 2, or grade 3, because that really takes what you do with these patients. And here we have also kind of an algorithm at our institution. It's based a lot about what we learned about blinatumomab, but we also use this now from our trial experience with more than 20 patients at our center across the board. That we use now this score system, we have adapted that. So we usually do MRIs and IIGs, very simpler, because we really want to exclude other causes in that situation. You always have to think there might be the underlying disease in that situation. And we might do also lumbar puncture to learn something, but also to see is the lymphoma or the leukemia or the myeloma hiding in that space. And then you should start dexamethasone only if and give TOSI only if you got cytokine release syndrome in that situation, and only Dex by itself. ICANS grade 2, supportive care, neurological workup as grade 1, as already looked at. More Dex, more intensified in that situation, and give TOSI only if you got cytokine release syndrome in that situation. TOSI really is not a place just for neuro by itself. ICANS grade 3, Dex, more intensified, ICU consideration, if seizures, Keppra for these patients, and if they go on to grade 4, then it's very similar like the cytokine release 4 situation. You give them 1 gram of methylprednisone in that situation. ICU transfer is mandatory and may have to be intubated because they really are off the rocks in those patients in the situation. And if this is, hopefully we don't see these cases, if they have cerebral edema, then we consult the neurosurgeon, because we have to really release the patient in that situation. But this is factually only been seen in 1% of the cases, generally speaking. So what about ID in this situation? So this is a graph that was a paper by Joshua and Blood, and it really shows you the overall incidence of bacterial infections, viral infections, fungal infections in patients. And you can see this is a relevant problem. We are approaching 20% and more some of these infections in these patients. And obviously, with the whole bunch of patients that we have leukemia patients which are really quite banged up because they came off an allotransplant, versus a lymphoma patient that is just his 2nd or 3rd relapse after responding. So they present themselves very differently, and you have to take that into consideration how to manage these patients. And this is sort of highlighted too, that disease makes a difference on the ID problems that you get. And again, ALL is the one where you get the most problems. when you compare that to CLL and NHL in a situation, that really will dictate how you think about these patients in that situation. And this is sort of shown as the incidence. 30% of the patients with ALL will get some ID problems across the board, and with NHL, it's just half of the patients that will have these issues. So what do we do? What do we do? Do we use ID prophylaxis? Yes, we do, because we're giving every patient fludarabine and cyclophosphamide. So what we do, we give them class severe in a situation, because that's what we anyway do if we give patients fludarabine. We do a PCP prophylaxis. That's the standard of care if you give fludarabine in a situation. There's no difference there. Bacterial prophylaxis, only for patients with ID with ANC below 500. Fungal prophylaxis, something that we would definitely consider, and we have two sets of patients here, low risk and high risk, and the high risk patients are patients post-transplant, for example, post-allo transplant, or a patient who has had fungal infections prior. We obviously would start them in post-transplant situation. Other ones can go just with fluconazole. IgG substitution, that's been discussed a lot. Here we have a very clear situation that we only give IgGs if the patient really has documented IgG low levels and has a history of severe infections. So very similar to what we anyway do clinically. So this makes a lot of common sense. And GCSF support we give to every patient who has prolonged neutropenia or comes down with ID infection situation. So in conclusion, I think altogether, and I think this has been highlighted also by my previous speaker, is I really strongly believe that CAR T-cell therapy should be performed in specialized centers. And it's a sort of, because you just need a lot of experience to do this, and you learn as you're taking patients. The grading of cytokine release syndrome, ICANS, based on the ABMC guidelines, has to be implemented across the board, has to be done. And the frequency of cytokine release syndrome and ICANS is influenced by several factors, by disease status, by age, and what you are targeting in that situation. And we might learn a lot when we are going into the myeloma space at our center, that we will find other issues that might be contributing here. And ID issues, infectious disease complications, are common in these patients, and you have to really be alert in the situation. And management according to guidelines are currently being developed, but I think we hopefully are very soon there that we can distribute something to everyone else. And thank you for your attention.
Thank you for this talk about this important topic. Questions?
Can I ask a practical question? Because I think the official SMPC says following discharge, the patient has to be within 2 hours of the center until day 28 or 30, but I think 2 hours is a little bit too long. What do you think?
I think it depends where you live. I think in Holland, it's 2 hours, you may cross the whole country.
But the ambulance won't drive for 2
The ambulance
hours.
might do that, yeah. Whereas I think in countries which are slightly larger, like Belgium, I don't know if that's true. No, but it's a good call. I think we need regional centers. I think that is, very important. I mean, there are some countries like the UK where you just have 5 or 6 dedicated centers. So I think that might be an issue to really comply with that. I think in Germany we're still looking at about 20-25 centers which were regionally well distributed. So I think that is very important, that there's a good distribution of centers and the patient should be local most of the time, at least for that period, definitely.
I had a question about the neurotox. You said it's often heralded by CRS, and in your algorithm you had DEX with 4 doses of TOSI, but I suspect then, does that mean you've used all your TOSI by the time you've got neurotox? And if so, then do you have anything else that you give? Do you give siltuximab or anakinra or mannitol or anything else?
Yes. So I believe with TOSI, once the 4 doses have been given, we are done. And if you have neurotoxins later on, let's say day 9, it doesn't make any sense to add that again to the mix and situation. You say it's saturated. There's always talk about Alkindra in a situation, the IL-1 receptor was a Nature Medicine paper, but I'm not aware of any clinical trial that has reported data of the use of that. And obviously there might be someone in the audience that has actually used it to prevent or to treat neurotoxicity. It would be great to learn what their experience is currently in this situation.
And I have another question. Would you consider a prophylactic anti-seizure medication when there's a product with high incidence of neurotox and the patient has fever already?
Yeah, I think Keppra is something that we also like to use. And again, as you already pointed out, I don't give it to every patient. I think like the myeloma patients, we would not do it.
Oh.
But someone who with high disease burden in NHL, I would really recommend giving Keppra in that situation. I think it's not, you get a feeling for the patients over time.
I think Monique correctly pointed out that we also have to take care we don't give all the prophylactic medication can also cause other symptoms, so we have to be careful not to pile up all the...
It's one thing also for a practical thing, if you give tocilizumab, what happens, you really don't see any more CRP, you don't see any more fever. So those patients come down, that doesn't really matter, it's just like for CAR T-cell, for generally speaking, for all kind of immunotherapy where we give toci, we re-blunt the physiological response to ID problems. And that can be quite prolonged. They can be 14, 15, 16 days later on. They still can't make fever. So you have to be very alert about that. And I think ID is completely important in this situation, that you have a very clear guidance on how to do prophylaxis in these patients.
And also what kind of workup you do for
Absolutely.
viral infections.
Yeah, it has, I mean, the CT scan of the chest is mandatory to us, the swabs to decipher if there's a viral infection coming on, blood cultures. I think I can't just emphasize it is so important to catch the bird early.
Thank you very much.